This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. In case you're new to the show, I'm a MedPeds-trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We have been coming to you since October of 2016, which is becoming a long time ago, with these podcast episodes on hospital medicine, just to go through the clinical effectiveness guidelines that we have. And today we have a very special treat for you. Now, before we get into what we're going to talk about, just as a reminder, the University of Pittsburgh does give free CME to anyone listening on the podcast. Just go down to the description, click the link, sign in with a free sign-in you can create. I make 4 or 5 questions per episode. I do not make them hard. And you can get free AMA Category 1 CME credit for courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. And believe it or not, if you're listening, this is not a COVID topic. All we've been doing is COVID, but this is not one of those. Here, I am very fortunate. I'm going to introduce our guest, and then once you hear his name, you'll probably know what we're going to talk about. I'm very fortunate to have with me Dr. Michael Moritz. Dr. Moritz completed his medical school and residency at the University of Chicago Pritzker School of Medicine, completed his fellowship in pediatric nephrology at Texas Children's Hospital, and from there, he moved on to the Albert Einstein College of Medicine, where he was medical director of the Pediatric Dialysis Unit. Dr. Moritz joined the faculty here at UPMC Children's Hospital of Pittsburgh in 1999, and currently he's the medical director of the Pediatric Dialysis and clinical director of the Division of Pediatric Nephrology. Dr. Moritz is a professor of pediatrics here at the University of Pittsburgh. His primary research interests are in sodium and water metabolism in children. He's an expert on the epidemiology, evaluation, and treatment of dysnatremias in children and adults. He's published and lectured extensively on this topic, including publications in the New England Journal of Medicine and invited lectures at the Pediatric Academic Society annual meeting. Dr. Moritz serves on the editorial board of numerous journals. He's editor-in-chief of Frontiers in Pediatrics and on the editorial board of Pediatric Nephrology. He's also winner of the Publons Peer Review Award. So, Dr. Moritz, thank you very much for joining us here to talk about maintenance IV fluids in children. Thank you for your time.
Hey, thank you for having me, Tony.
All right. Well, Mike, let's do our disclosures because this is a CME podcast. So I will go first and I'll kick it out to you. I have no conflict of interest disclosures to disclose.
I have received some honorariums and consulting work with Alnylam Pharmaceuticals.
Now, Mike, this topic comes up a lot. As a hospitalist, when I'm on service, my residents, medical students are constantly asking about maintenance IV fluids, why different parts of the hospital use different things. So I was very happy to read the guidelines, go through them extensively, and have you on to talk about this. So without further ado, let's dive right in. So before we talk about the guideline itself, would you mind giving us a little history on maintenance IV fluids in children, and maybe even on the Holiday Seeger group and method?
Great. So, IV fluids have actually not been around that long. It's only within the last 100 years that an IV could even be put in. The cannulas could even be put in. So when that came about and IV fluids came about, we didn't really have any basis on how to prescribe IV fluids. And all of the calculations were all theoretically based. And they were theoretically based about the average concentration and dilution in the urine. What would be average solute load in terms of sodium and potassium, and how much urine would be generated, and what's the halfway point between concentration and dilution? And the theoretical calculation came out with about half normal saline for adults, approximately. This was in the 1940s. So, and with this theoretical calculation, the amount of IV fluids for an adult was around 3 liters of fluid, which is a significant amount of fluids. So for pediatrics, that amount of fluids was being given, but pretty much adjusted for body surface area. It was about 1,500 milliliters per meter squared per day. In the 1950s, Holiday and Seeger came up with a way of prescribing IV fluids. Instead of having to do it based on body surface area, doing it based on weight. And that's the formula that we're really familiar with, the 150-20 or the 4-2-1. And that's about 1,500 milliliters per meter squared per day. What's important to realize is that's actually how we prescribe pretty much all the medications in the hospital. When you look at the hospital formulary, you see that the dose of a neonate is pretty large per kilogram. A child is somewhat smaller, and an adult is much smaller. Well, if you dose that medication based on body surface area, it would be the same. So if you have a chemotherapeutic drug or a biologic, it's actually dosed in body surface area. That's the very precise way of dosing it. And the reason being is that body surface area more closely approximates your basic metabolic rate than weight. So when you're prescribing any medication in children and you notice there's a different dose for neonates versus older kids, that's sort of like a fudge factor for body surface area. Fluids are the same way. So Holiday Seeger came up with a way to prescribe IV fluids as if it was 1,500 milliliters per meter squared per day, but without having to calculate body surface area, which was very difficult in the 50s because we didn't have calculators, we didn't have EMR to do that. So that was a big novelty. At the very end of their paper, they said, well, what do we do about composition of IV fluids? The paper was not about composition. They said, well, what do we feed children? We feed them formula and we feed them cow's milk. And what's the concentration of sodium in cow's milk and in breast milk? And it's about a quarter normal saline, 30 milliequivalents per liter. So they said we should give them quarter normal saline. And it sort of stuck. Now what happened is people started saying, well, okay, we've got the Holiday Seeger formula, 150-20, and we'll just take 30 milliequivalents per liter and call that 3 milliequivalents per kilogram. Well, now you've got IV fluids where the rate is different, 100 mLs per kg, 50, 20, but you're holding the sodium concentration the same, 3 milliequivalents per kilogram per day. So what happens? You get quarter normal saline for younger kids, half normal saline for older kids. Now, around the same time that Holiday and Seeger published that paper in 1957, actually about the same year, is when Barter and Schwartz reported the first case of SIADH. It had not been described yet. It had theoretically been described by Leaf. They had taken healthy volunteers and given vasopressin, but SIADH did not exist at the time. And since then, we know that there are numerous stimuli for vasopressin in acutely ill patients. And a good way to think about it is that vasopressin is a physiological stress response. In a fight or flight situation, it makes sense to have high vasopressin and conserve water. But this hypotonic fluids sort of stuck in the adult side and the pediatric side from the 40s and 50s. And then hyponatremia just became more common, more recognized. SIADH was better understood, and we just found out a lot of things cause it, different diseases, different medications, and essentially all acutely ill hospitalized patients are at risk for hyponatremia. But people just kept on using hypotonic fluids. And in fact, there was never a guideline. There was never a consensus statement. It was all opinion-based. And that's when, in the early 2000s, we proposed using normal saline to prevent the development of hyponatremia because there were numerous reports in the literature of children dying with hyponatremic encephalopathy.
Now, Mike, I read you were a part of the first group to do that, to actually recommend normal saline for maintenance IV fluids for children. Is that right?
Correct. Yeah, we reported that in Pediatrics in 2002, and we did that based on numerous reports of deaths in children. My mentor at the time, I started this project when I was a fellow in Houston, Texas. My mentor at the time, Carlos Ayus, had a very large case series of numerous children who died from hyponatremic encephalopathy from very minor surgical conditions, tonsillitis, orthopedic injuries. He had some patients with pneumonia as well. But these are kids who died receiving hypotonic fluids. And we partnered together and wrote a manuscript suggesting why it makes more sense to give normal saline. And Holiday and Seeger, in fact, wrote an editorial in the same issue calling that practice into question.
Your idea in the question, or
yes.
The old? Oh, wow!
Yeah, in the same issue, they took a stand against us, and actually they wrote many papers after that trying to say that was not a good idea.
Wow! I mean, there's some historical reference there, which is kind of looking back now for me as someone not involved in it. Clearly, it's interesting the fact that they wrote those articles. that's kind of fun. But so let's talk about the guideline. So what we're talking about is the guideline from 2018, Clinical Practice Guideline. This was published in Pediatrics, issue 142, number 6. First authors, Dr. Leonard Feld and then Daniel Newspiel, and that's a number of authors after that et al. You were, of course, the last author on that, and there's a subcommittee on fluid and electrolyte therapy. So I'm going to get into a little bit of the basics of the guideline, then we're going to ask you some questions about it. So first, the goal, which is always nice to start with. The goal of this guideline was to provide an evidence-based approach for choosing the tonicity of maintenance IV fluids in most patients 28 days to 18 years of age who require maintenance IV fluids. Now, this guideline applies to kids in surgical, post-op, and medical acute care settings, including critical care and the general inpatient ward. Now, who it doesn't apply to is patients with neurosurgical disorders, congenital or acquired cardiac disease, hepatic disease, cancer, renal dysfunction, diabetes insipidus, voluminous watery diarrhea, or severe burns, neonates who are younger than 28 days old or in the Nicu, and adolescents older than 18 years old are also excluded. Now, right off the bat, this brought up a question in my mind. Is one of the main questions I get from residents and medical students when I'm on service is why does the Nicu always use half normal or quarter normal still? And if we get a similar age baby, let's say in for hyperbilirubinemia with a newborn, or just leaves a Nicu and comes to us a day later for one reason or another, we will then use normal saline. So then my question to you was going to be, why are the Nicu and neonates younger than 28 days old excluded from this guideline? Are they different? Is there a difference in the amount of literature we have on them?
Right. So there's two reasons. In terms of the guideline, there was no literature. We had no literature to base it on. And most of the studies that were done were outside of the neonatal period. So one issue is there was a lack of literature to base it on. But even without that, can you extrapolate it to neonates? No. One reason why hypotonic fluids are so used in neonates is there was some very early literature that, especially in puppies, that they have a relatively inability to excrete chloride. Neonates do have high renin and very high aldosterone, and if given a large saline load, they don't excrete it quite as fast as an older child. Now, that probably doesn't apply to maintenance fluids. If you're giving a fluid as a maintenance rate, it is probably irrelevant. But that was a sort of an ingrained practice that neonates have a relative inability to excrete chloride. Now, whether that actually applies to kids all the way up to 28 days is unclear, but there is a lack of evidence in it. But what do we do know? We do know that neonates get a lot of hyponatremia, and neonates can have SIDH and acutely, and there is a lot of hyponatremia in the neonatal intensive care unit, and we do know that hyponatremia is bad for neonates. It's bad for brain development. It's bad for growth, and they're at very high risk for hyponatremic encephalopathy, and there have been a lot of deaths reported. So you can absolutely make a good argument to use normal saline in that age group. Now, you take an example of a child with bilirubin, hyperbilirubinemia. Well, hyperbilirubinemia causes an encephalopathy. You have bilirubin encephalopathy, so that can cause, brain injury, and that is not the kind of person that you want to submit to a cytotoxic injury, having low sodium that can go inside of the brain. So that would be a good group to, potentially give normal saline to.
Okay, so I like that because the explanation I always got from neonatologists is exactly what you said, which is above that 15 milliequivalents, I think, per kilo per day. Neonates have a hard time excreting the sodium, and they're more likely to get hyperchloremia, which is what you talked about in the dog study or the puppy study. But we don't have enough data to really say one way or another. But in your opinion, probably it's okay to give normal saline.
Right. And I'm glad you brought up that 15 milliequivalents per kilogram per day, because this is something that comes up a lot. It's like, well, wait a second. You're going to give someone 15 milliequivalents per kilogram per day of sodium? That is an enormous amount of sodium. And if you gave an adult that would be a tremendous amount. That's true. But remember, that's not how we prescribe fluids. That's not how we prescribe meds. Neonates get a much larger dose per kilogram than older children and adults, but on body surface area, it's the same amount. So when you give an adult normal saline and you give a neonate normal saline, the neonate's going to be getting 15 milliequivalents per kilogram per day. The adult's going to be getting 4 milliequivalents per kilogram per day. But per body surface area, it's going to be the exact same amount. Remember, a child is getting fluids 150, 20. Mm-hmm. You cannot report one thing in terms of body surface area, 150, 20, and then compare it milliequivalents per kilogram. I mean, it doesn't work that way. You can give a neonate 15 milligrams per kilogram of Tylenol. You're not going to give 100 kilogram, adult. That kind, it doesn't work that way. So the bottom line is, if you give a neonate normal saline, it's the same as giving an adult normal saline. Per body surface area, it's the exact same amount of sodium that they're getting. So it's misleading to report it in milliequivalents per kilogram when you're reporting the fluid volume in body surface area or 150/20. It's not the same.
I've never heard explained, but that's really helpful. Thank you. Now, one of the things in the beginning of your guideline, you really go into, the guideline is redefining tonicity versus osmolality, because for me, unlike you probably, it's not something I think about on a regular basis. I would assume for you it's something you think about on a regular basis. I'm going to go through and tell you how I understood it, and then you can tell me how wrong or right I was. So I read that tonicity describes the net force vector on cells relative to a semi-permeable membrane when in solution. And that membrane was the key, because you talk about osmolality, is just really, it's measured as osmoles of solute per kilogram of solvent. So tonicity relates to both the effect on a cell of a fluid, depending upon the selective permeability of the membrane, and the osmolality of the fluid. And then you give the example of urea, where urea affects osmolality, but not much tonicity because it can freely move across the membrane. So there's no the permeability is full. Did I understand that right?
Correct. Now, you understood it beautifully. Now it's confusing, though. This is a confusing kind of thing. So I'll try to explain it. There are something called effective osmoles and ineffective osmoles. Effective osmoles are osmoles that can cause water to, move across the cell membrane. Like, for example, if you become hypernatremic, if someone's sodium goes from 140 to 190, water is going to be pulled out of the cells into the extracellular space, and that's going to cause cell shrinkage. Well, what if someone has a BUN of 300? What if they're, in the ICU, they're in the cardiac ICU, and they're being diuresed like crazy, and the BUN just keeps going up and up and up and up, above 200? They have a high osmolality. If you send the blood to the lab and you measure their osmolality, they are hyperosmolar. They're not hypertonic, though. It doesn't harm the brain in any way whatsoever. It doesn't pull water out of the cells. It's an ineffective osmole. So that is not hypertonicity. Hypertonicity is in the blood is either a high sodium or a high glucose. So where is this relevant? Okay, great. Why do we care about this? Because when you look at an IV fluid bag, let's say you look at D5W, you pull the bag, you look at it. It's going to say that it has an osmolality of 272, which is about the same as the plasma. It is isoosmolar. Why? Well, you can't just give water through a vein. If you give water through a vein, it will cause the red blood cells to lyse. Now, if you give D5W, that is isoosmolar. When you give that through the vein, it will not cause red cells to lyse. But what happens once that D5 goes into the bloodstream? Well, your body metabolizes it to carbon dioxide and water. It doesn't stay, you don't become hyperglycemic. So in fact, it's like you give D5W. But people get mistaken and they say, hey, wait a second, D5, normal saline, wait a second, that's an osmolality of 600. That is a hypertonic solution. No, it's not a hypertonic solution. The D5 it's hypertonic in the bag, but it's not hypertonic in the bloodstream. People can also get very confused this is beyond the scope of it, but when they're trying to understand urine osmolality. Urine osmolality can be very high, but can have very little sodium. It can all be urea, which means you're losing free water. So what we really care about is the sodium and potassium concentration. That's really all that's relevant. So when someone says, and this could happen, you want to give D10 or D20, normal saline, they say, no, you can't do that. You can't give that through a peripheral IV. That's too hypertonic. Well, that's true. If you get too hypertonic, you can sclerose the vein. But once it goes into the bloodstream, it's irrelevant. The dextrose will be metabolized. So as far as hyponatremia, hypernatremia, all we're really concerned about is sodium and potassium.
And so you're only concerned about those because those are not the ones that are freely permeable across the membrane. So that's when you can get changed cellular expansion or cellular shrinkage, which can cause harm.
Correct. Unless you have uncontrolled diabetes, the dextrose is irrelevant.
That's great to know. Now, I want to get right, and we're going to get back to dextrose, I think, in a second, because I want to talk about that for a minute. But I want to get in your first key action statement, because it brings up, because you brought up potassium. So your first key action statement, well, the only one, 1A, kids 28 days old to 18 years of age requiring maintenance IV fluids should receive isotonic solutions with appropriate potassium chloride and dextrose, because they significantly decrease the risk of developing hyponatremia. And that's quality A evidence. What struck me about that was the potassium chloride. When I trained, and I think you may have been one of the reasons this stopped happening, is we always used to give maintenance IV fluids with whatever composition, but with 20 milliequivalents per liter of potassium chloride all the time. I remember my program director was a stickler about that. We stopped doing that. Is the guideline saying we should be giving potassium chloride with every maintenance IV fluids?
Yeah, so that's a really good question, and this is something that needs to be resolved. The guideline did not make any recommendation about how much potassium to be put in IV fluids, because that has something that has never been studied. Now, I want to qualify that, because there was a paper that recently came out from Europe, and they compared a balanced solution. I'm trying to remember. I think it was Plasmolite. I don't quote me on that, but it was a balanced solution versus half normal saline with 20 of K, and they found that patients who got a balanced solution, did not have any potassium, had more hypokalemia than patients who got 20 of K. Now, the problem with that study is they enrolled patients who had hypokalemia, meaning you could be enrolled in the study if you had a potassium less than 3.5. They excluded people who had a potassium less than 3. So, well, if you have someone who's hypokalemic and you don't give them potassium, and they are looking at electrolytes anytime after study enrollment, you get a potassium checked a couple hours later, well, you're going to have a low potassium. I mean, you're not going to correct hypokalemia without having potassium in the IV fluids. Or if you have someone who has voluminous diarrhea, which they included kids with lots of gastroenteritis, and you don't give potassium, that can happen. Or if you're giving a balanced solution that has bicarbonate and someone who's acidotic, now you have the acidosis that corrects, you become alkaline, potassium is going to move into the cells. So there were problems in that study, but in terms of giving 20 milliequivalents of potassium to everybody, where does that come from? Why? What's the reason for that? Has anyone shown that it's safe? Because first of all, what we do know, what do we know for a fact? We know that most patients are on IV fluids for less than 24 hours. Very few are on IV fluids for greater than 48 hours. Numerous studies have shown that. So kids are on IV fluids for a short period of time. What else do we know? We know hyperkalemia is a bad thing. You're trying to send someone home, you get labs, it could be hemolyzer, who knows what, and you get a potassium of 6.2, you have a potassium of 5.8, now you have to do all kinds of, machinations and repeat it. Well, if you don't have potassium in the IV fluid, you don't have to worry about it. We do know that hyperkalemia will kill you. We know that hypokalemia won't. A potassium of 3.2 is not going to kill anybody. Now, there may be exceptions here. If you have a cardiac patient who's very prone, to arrhythmias, there may be situations where you don't want to have any hypokalemia at all. But for the most part, it's pretty well tolerated. And now we're having sicker children with AKI, with different medications that can cause hyperkalemia. So we didn't really have enough evidence to say you have to put 20 milliequivalents for potassium. So people have to decide what is appropriate. If you admit someone and they're hypokalemic, or they're having lots of vomiting and diarrhea, they're going to need potassium. But under many situations, it might not be needed at all, and it might be better to avoid this. We do know that normal saline, depending on how it's given, it can cause a dilutional acidosis. It can cause a hyperchloremic acidosis, and it can cause hyperkalemia just from that. So it's not so simple just to say everyone should get 20 milliequivalents of potassium per liter.
Okay. Now, we talked about the glucose, and I said I wanted to get back to that. This may be a bad question, so forgive me for it if it is. But part of my internal medicine training, when we did it, we had a nephrologist talk to us constantly to say you don't need to give dextrose in the maintenance IV fluid solutions. It's irrelevant the amount of dextrose for adults. In pediatrics, it's very different. We have the glucose infusion rate. We give the dextrose. Your guidelines talked about how the glucose is rapidly metabolized in the bloodstream. So why do we put dextrose in maintenance IV fluids in pediatrics? Can you elaborate on that a little bit?
Mm-hmm. Yeah, so, the reason why we put dextrose in the IV fluids is because you do need, in order to metabolize efficiently, you need a certain amount of dextrose, or else you're going to become ketotic. You're going to start breaking down fats. You're going to be breaking down, muscle. And in children, they are we are dealing with, growing, children who need calories. So there is a basal amount of calories that you need to become catabolic. And D5 in maintenance fluids is about that amount. And I'm sure you've all seen it I see it many times. You'll see kids who'll come into the ED and you'll get a urine dip and they're testing positive for ketones. And that happens. So that's really basically why we have a basal amount of dextrose.
Now, the next part of the guideline is the methods section. We're not going to get into that too much. I did want to quick read what you all did for those listening at home, just who are curious. The subcommittee combined the search strategies in 7 recent systematic reviews of clinical trials of maintenance IV fluid in children and adolescents. They made a super systematic review, which was then used to help develop the guidelines. They used the classic AAP rating of evidence, which we're all used to and have been gone over in previous podcasts. And there was even a thorough assessment to evaluate for risk bias. Now, critics of the guidelines claim that since there is no number needed to treat and number needed to harm to compare, the guideline isn't as good as it could be. It's misleading to claim that there's strong evidence of anything. Do you agree with this or not?
Yeah, okay, so that's a good question. I do disagree with it, but I want to explain why. So the worst possible outcome of hyponatremia is hyponatremic encephalopathy, someone dying of cerebral edema. That is the worst possible outcome. Now, that's not the only possible outcome. We know there's a lot of other things that hyponatremia does that's not good for you. It's been pretty well established. It's an independent risk factor for hospital, mortality, in-hospital mortality, 30-day mortality, increased length of hospital stay. So there are other things associated with hyponatremia. But the worst thing is hyponatremic encephalopathy. Fortunately, it is rare. It is a rare complication, but it does happen. Now, there is no way anyone can design a study and say, look, we're going to give 2 fluids, and you know what? If someone develops hyponatremic encephalopathy and they die, so be it. So be it. We're just going to let it happen. We're going to check the sodium, and if it goes to 123, doesn't matter. Just keep giving the half normal saline. Keep giving the quarter normal. If they start seizing, no, let's just see what happens. Just let them die. We can't do that. No. If someone's hyponatremic, they're not enrolled in the study. If the sodium goes below a certain point, they have to be withdrawn. There has to be safety mechanisms. That's why we cannot enroll neurosurgical patients. You can't take a neurosurgical patient who has cerebral edema and give them quarter normal saline and kill them. You cannot do that in a study. You cannot take a patient with congestive heart failure who is at risk for hyponatremia and fluid overload and say, well, we're just going to give them quarter normal saline at maintenance and sort of see what happens. That is not going to make it through the IRB. You can't do that. So it's not reasonable to say, well, wait a second, you didn't prove that anyone died from hypotonic. That wasn't the point of the studies. The point of the studies was to say, hey, which fluid maintains the serum sodium better? Normal saline or a hypotonic fluid. Now, it also looked at different things: fluid overload, hypertension, hypernatremia, acidosis. There were, and the guidelines, go through those things. So they did look at other things, but you cannot, do a study where you're going to let someone die.
Well, I fully agree with that. I got to tell you, I fully agree with that. I think that makes a lot of sense. You brought up the Hyponatremic Encephalopathy. In the guidelines, there were, clearly a fatal, it's an emergency, irreversible brain injury if inadequately treated. What I didn't know that was there, which I appreciate you all putting in, is that the reason children are particularly high risk of developing symptomatic hyponatremia from specifically encephalopathy is due to their larger brain to skull size ratio, which I did not know prior to reading this. I don't think I've ever come across that. And then just to round it out for people listening, non-specific symptoms for hyponatremia, some of them can be very non-specific, like fussiness, headache, nausea, vomiting, confusion, lethargy, and muscle cramps. The next thing I wanted to talk about is lactated ringers. There's a couple of topics that I really want to bring up because I'm constantly asked about it on rounds. Now, lactated ringers wasn't involved in any of the studies that were used in the guidelines. Its sodium concentration is 130 milliequivalents per liter. Its osmolarity is 273 milliequivalents per liter. What's your opinion on the use of using lactated ringers as maintenance IV fluids for pediatric hospitalized patients?
Okay, that's a really good question, and I'm just going to give a couple of guides, because first of all, what we wrote was a guideline.
Right.
It's a guideline, and we bring the issues to consider. So there's not one right fluid for everybody in every situation. There's not one right rate, so it's a guideline. So I'm just going to give you some guidelines related to lactated ringers. First of all, there is a misconception that lactated ringers is an isotonic fluid. What do I mean by that? Meaning there's no difference between lactated ringers and normal saline. It's like they're the same. They're an isotonic fluid. If you give both of them, as far as the sodium is concerned, you're going to have exactly the same outcome. No, that is not true. Normal saline has a sodium of 154. Lactated ringers has a sodium of 130. There is a difference. It's a near isotonic fluid. You're going to say, well, but no, you're wrong. See, normal saline is a hypertonic fluid. See, it's 154. The plasma sodium is 140. Normal saline is actually a hypertonic fluid. Now, that's actually not correct. Why? Because the plasma is not all water. The plasma is 93% water, 7% fats and lipids. So the sodium concentration in all of the plasma is 140. But the sodium concentration in the plasma water, and just the 93%, is 150. And if you add 4 for potassium, you get 154. So normal saline is perfectly isotonic. And lactated ringers is more hypotonic than you think if you realize that the sodium in the aqueous phase of plasma is really 150. Now, why is that relevant? Because there are certain situations where you really don't want to have any hyponatremia at all. Now, if you have someone with meningitis, encephalitis, a neurosurgical procedure, someone who's high risk for cerebral edema, then you really don't want to give lactated ringers. If anything, you want the sodium to be on the high side. So you don't want to think that under all circumstances, the fluids are exactly equal. And as you pointed out, Tony, most of the balanced solutions that were in the study were plasma-light. Now, we don't use a lot of plasma-light, and the reason being in the United States is there's no such thing as D5 plasma-light. You can get it in Europe, you cannot get it here. Now, if you could get D5 plasma-light, that would be the preferred solution to use. You can get D5 lactated ringers. So it's a near isotonic fluid, but here's the kicker. If you take D5LR and you add 20 of K, now you have a perfectly isotonic solution, because now you have a tonicity of the sodium plus the potassium is now 150. So if you're giving D5LR with 20 of K, now you're in business. You've got a perfectly isotonic solution. And if you like giving 20 of K, you're good to go. I do like balanced solutions, by the way. If I had a perfectly isotonic balanced solution, I would use it. Now, why do I say that? Why do I say I would use it? Well, because I have kids with renal disease. My kids have acidosis. I mean, if I give normal saline to my patients who have chronic kidney disease, who cannot acidify normally, or who are on transplant patients, my patients, when I give them normal saline, it happens all the time. I'll bring in a transplant patient, and I'm hydrating them for a biopsy, and they'll come in with a bicarb of 22. The next day, it'll easily be 18. because they have renal tubular acidosis. They have renal disease. So I'm frequently adding bicarbonate to my fluids. Frequently, I'll use half normal saline with 70 milliequivalents of, bicarbonate. Many of my patients are on bicarbonate at home. They're on bicarbonate pills. So there are reasons when you want to have a solution that has bicarb in it. Lactated Ringers is an intraoperative fluid when you're maybe giving 3 or 4 liters of a hypotonic solution and they're leaving the OR hyponatremic. Probably not a good thing. Plasma-Lyte would be preferred. Now, I don't know if I answered your question, but the real reason why this is becoming a very hot topic is because there is some literature that suggests that if you give large amounts of normal saline intraoperatively or as a bolus solution or as a resuscitation solution, that it can cause acute kidney injury and it can cause increased mortality. And there was 2 very good papers that came out in the New England Journal that suggested that, the SALT-ED and the SMART trials, and they were very large trials. They had about 30,000 papers. Now, they weren't exactly random. They were pragmatic studies. So 1 month they got one fluid, another fluid, they got another fluid, and they had lactated ringers or Plasma-Lyte. And they suggested at a very small difference, about a 1% difference. The problem is no one else has been able to show that. And there have been other randomized studies that have looked at it and have not been able to describe what they've found. And there's 2 large studies that are ongoing now, they've been ongoing for years, and they have not been able to find that. They're continuing to try to enroll patients, and they might not be able to enroll enough patients. So it's not a settled issue. That is not fact. When something gets published in the New England Journal, people tend to think, well, that's it. That is fact. There's nothing to talk about. It's a closed topic, and that's not the case. It's not so clear, and that may never be proven. It certainly has not been proven yet. So there's nothing wrong with using normal saline, at this time. And you just need to be aware that if you use lactated ringers, you can expect a small fall in serum sodium. It's only going to be it depends on the situation. Generally speaking, it's only a couple milliequivalents per liter. I may have gone over my time, but I do want to mention one other thing. Normal saline is not perfect, okay?
Okay.
If you're in a situation where someone has SIDH or they have very high vasopressin, you can get hyponatremic on normal saline. And this has happened. So, for example, and unfortunately this exists, this is in the literature, there's something called marathon-associated hyponatremia. People are running a marathon, they're popping NSAIDs, they're a slower runner, they're stopping at every rest station, drinking like crazy, they're in pain, and they come to the rest stop and they're, hyponatremic, and they're having symptoms of hyponatremic encephalopathy, and then they get treated with normal saline. Well, if you give someone with very high vasopressin who has SIDH and you treat them with normal saline, the sodium will fall further and you can die. There's people who've died from getting normal saline. So normal saline is not perfect in preventing hyponatremia. It's just a lot better than anything else. There's about 5% incidence of hyponatremia. So again, these are guidelines, and under certain circumstances, even normal saline can cause fall in serum sodium. That's usually not very much, but depending on the situation, sometimes a small fall in serum sodium can be dangerous.
Now, I'm glad you brought that up. I love that answer, and I have all the time that you have, to be honest with you, so you don't have to worry about time. In the guideline, you stated that numerous studies of adults have revealed that a mild and asymptomatic hyponatremia can be associated with deleterious consequences, and it's actually an independent risk factor for mortality and leads to increased length of hospitalization and increased costs. Now, just so we know just so we're all on the same page for definitions, you define mild hyponatremia as 130 to 134 milliequivalents per liters, and moderate as 125 to 129 milliequivalents per liter. So my question to you, and you didn't really talk, the guideline didn't state why this happened. It was a bit of a surprise to me. Do you have an idea why this is happening? What's the pathophysiology, or what's occurring?
Yes. So I'm glad you don't have a limit on time. Yeah. So I want to take a little bit of time to talk about this to best answer this question. I'm going to go back in time.
Okay.
Tell you a story. When I was at Albert Einstein as a new attending, as my first attending, position, I had to be on the general pediatric service. It was a requirement. You had to do, a general, and I had to do that here, by the way, when I came, I had to be a general pediatric attending. It's pretty cool, actually, because, you see a part of something that you don't usually see and things, and you look at things in a fresh perspective because you don't look at it all the time. And I remember when I was on the general pediatric service at Einstein, we had a bunch of kids with bronchiolitis, and they all had a sodium of like 132 and 133 and 134. And I'm like, these guys are hyponatremic. And they're like, no, this is normal. All kids with RSV have that. That's normal. Well, just because something's common, just because you see it all the time, it doesn't mean it's normal. It doesn't mean it's a good thing. So sodium is the most abundant electrolyte in the body, and actually a lot of it is in the bones. It's not just in the plasma, it's also in the bones. And it's a very important neurotransmitter. When someone's sodium goes below 135, and I want the audience to listen to this very carefully. When someone's sodium is 135, they are not going to be acting normal. Why do I say that? Go look at I don't know the age of the people in the audience, but maybe your mother, if you're in your 50s or something like that, or your grandmother or your great-grandmother who frequently have hyponatremia. When they get hyponatremic, they don't walk straight. They start getting loopy. They can have balance problems. They're neurologically not functioning well. I'll see patients in the hospital who have hyponatremia, older patients, because we have patients in the early 20s. When they're hyponatremic, they'll be reading the newspaper, and I'll ask them, are you reading as fast as normal? And they're like, you know what? No, I like reading, but I'm not getting it today. When your sodium it's been studied. They have done cognitive testing. If your sodium is less than 135, your cognition is not going to be 100%. It's going to slow you down. And your nerve reaction time is not going to be the same. You will not be able to walk straight. If an elderly person has a sodium less than 135, they neurologically function as someone who's had 2 drinks of alcohol. Now, again, this is subtle. And remember, there's something called osmotic stress, that when the sodium falls, you now are having osmotic stress to the cells. The cells respond to hyponatremia because they're going to swell. But how do they not swell? They extrude osmolytes. They extrude sodium and potassium, and they extrude amino acids. So what does that mean? Well, for the brain, some of the amino acids, there's different ones, taurine and whatnot. There's different things that they extrude, but one of the ones they extrude is glutamate. Glutamate is an excitatory amino acid. It's an ammonia-based amino acid. It's a neurotoxin. So sometimes you'll have someone who's hyponatremic and who absolutely 100% does not have hyponatremic encephalopathy. Like if you do a CT, there's no question about it, they don't have hyponatremic encephalopathy. But they can be seizing because they're having electrochemical seizures. The glutamate is neurotoxic. It's an excitatory amino acid, and it can provoke seizures. So that's why when you're hyponatremic, you can have muscle cramps because, it's causing osmotic stress. It can cause arrhythmias. And what we do know in both children and adults, if someone has prolonged hyponatremia, as can happen with epileptic medications, we have patients on Trileptal and whatnot, they're hyponatremic. The family's like, don't you dare stop this medicine. It is the absolutely only seizure medicine that works for my kid. We are not stopping it. And what happens is they come in with fractures. Or if they get a bone densitometry, they have bone demineralization because in order to keep the sodium normal, the body is mobilizing sodium from the bones. So there's something called allostasis. When you're hyponatremic, it causes cellular stress to basically every cell in the body. I mean, I don't know if this is like a good example. It's what we now know about vitamin D deficiency, that when you're vitamin D deficient, it doesn't just affect your bones, it affects your immune system, it affects other things. So I would say hyponatremia is a systemic disease. It affects you, systemically. And now we're finding that, study after study after study, that patients who are hyponatremic do worse. Again, if you're a very healthy person and you have no comorbidities whatsoever, mild hyponatremia is probably not a big concern. But if you're fighting for your life and you have many other comorbidities and there's a lot of other things that you're trying to deal with to survive, and now you're adding osmotic stress to all the other problems, that could be the one thing that, pushes you over.
That is fascinating. Now we're going to get to the part of the talk or the podcast episode that I was very excited to read. Your explanation for that was wonderful. Thank you for doing that. When I started reading these guidelines, I actually turned initially to the section on hyperchloremic metabolic acidosis, because I have to tell you, I get this question, especially from my med-peds residents, all the time, because I think it's more pronounced in the adult literature. Now, in the guidelines that you were part of, it stated hyperchloremic metabolic acidosis has been associated with 0.9% sodium chloride, normal saline, when it's used in resuscitation. And you talked about this a little bit already. I'm right in saying you can get hyperchloremic metabolic acidosis with large boluses in volume, like in OR resuscitation in pediatric patients, from 0.9% sodium chloride. Is that right?
Yes, that is correct. But I'm going to back up and put it into some kind of a context, because we have a problem here. Why do we give normal saline? We have a problem in that, just for your readers to really understand the problem that we have, is all the fluids that we have are grandfathered in. None of them are FDA approved. None of them were studied, and none of them were FDA approved. And we put fluids in polyvinyl chloride bags. Okay? Now, where do these polyvinyl chloride bags come from? How is this a thing? Where did this come from? I'll tell you where it came from. We used to put IV fluids in glass bottles. And if you look at, old literature on IV fluids, you'd see these glass bottles hanging at the bedside. And we still do this for some things. They come in glass bottles. So what happened is for dialysis solutions, they used to be in glass bottles. You could Google and you'd see 40-gallon, big glass bottles for dialysis solutions. Super expensive, very heavy, hard to dispose of. But the drain bags for dialysis were these polyvinyl chloride bags. They were garbage bags. They were waste bags. And a dialysis physician in Toronto said, "Hey, can we put fluid in these drain bags? Because this would be so much better than the glass." So peritoneal dialysis solution went into the drain bags, these polyvinyl chloride bags. The problem with the polyvinyl chloride bags is they're permeable to carbon dioxide. So you can't put bicarbonate in them. So you have to put lactate. Peritoneal dialysis solution has lactate. So you could put normal saline in it, but you couldn't put bicarb in it because it won't have a long shelf life, which is the same reason that you don't buy beer in a plastic bottle. You buy it in a glass bottle, or you buy it in a can. Or if you have an expensive food, expensive, fruit or something like that, you want to have a long shelf life, it will not be sold in a plastic jar. It's going to be sold in a glass or in a can because it's not permeable to carbon dioxide. Well, it's the same way with IV fluids. No IV fluid bags have bicarbonate in it. So you cannot put bicarbonate in a bag and have a long shelf life. So even balanced solutions are not balanced solutions. I mean, they're balanced, but they're not physiological. Lactated Ringers has lactate. Plasmolite has acetate and gluconate. We do not have a perfect solution. Now, if you had an aluminum foil around the bag, you could probably put bicarbonate in it. So we don't have a perfect choice here. Now, because normal saline doesn't have any bicarbonate in it, if you give liters of it, and when you give an isotonic fluid, it all stays in the extracellular space, 100%. None of that is going to go intracellularly because it's isotonic. You have to take my word for it. I mean, I could try to explain it more, but if you give water, let's say you acutely give D5W, 2/3 will go intracellular, 1/3 will go extracellular because the membrane is permeable to water. But the membrane is not permeable to sodium. If you give an isotonic fluid, it all goes in the extracellular space. So if you give someone if you drop in 3 or 4 liters of normal saline, that is all going to go extracellular. That will dilute the bicarbonate. It has nothing to do with the pH of normal saline. It has nothing to do with the chloride concentration of normal saline. It has nothing to do with it hyperchloremic. It simply does not have bicarbonate. you're giving it to it the extracellular space, you're diluting it down, your bicarbonate level is going to fall. That is a fact, and that will happen. Now, whether it's clinically significant is a different thing. Having someone's bicarb go from 124 to 120, is that clinically significant? Does it cause a problem? Is it harmful? We're not really sure, but maybe it is. I don't know. I mean, we really don't know. So I'm not taking a stand one way or another. The literature really is unclear on it. But what it's not unclear about is, does it happen? Yes, it does happen. You give 4 liters of normal saline to someone, the bicarbonate level is going to fall. That is, for a fact, going to happen. And if you give them a balanced solution that has a base equivalent, that's not going to happen.
So if I'm understanding this correctly, you're saying that the bicarbonate falls because of the dilutional effect from all of the fluids you're giving, and the isotonic fluids are staying extracellular. And so then the metabolic acidosis could be due to just the dilution of the bicarbonate?
Correct. Now, that probably will not happen in a maintenance solution, because remember, you're not giving 4 liters. Let's say, we'll just say an adult-sized kid, you're giving them 100 milliliters per hour. So, and the kidneys can generate bicarbonate and excrete acid, and they should be fine. That may not be true in someone with renal failure. Now, if you have, in my patients who have renal failure, that's different. They could get acidosis with maintenance normal saline. But I'm dealing with a special, population of patients whose kidneys don't work normally. But if your kidneys work normally, normal saline as a maintenance solution should not cause any appreciable degree of acidosis. Though, as you said before, I don't have a problem with someone giving D5 plasmolite, or there's nothing wrong with that. Understanding that D5 plasmolite has a bicarb equivalent of around 50. It is an alkalotic solution. So if you have someone who's on diuretics, or who have someone who's vomiting, you can make them very alkalotic. Also, the same thing with lactated ringers. What if you have someone with lactic acidosis, or someone who's septic or whatnot, and you're bolusing them with, lactated ringers? Well, it's lactate. Or if you have, you're in the cardiac ICU and you have someone who has poor perfusion, and they have a detectable level of lactate, you're giving them lactate. So you can see here, it's not so simple. It's just not so simple. You just can't say, well, balanced solutions are good and normal saline is bad, and just give lactated ringers, I don't have to worry about anything. It's not that clear. It's not that simple.
Okay, so then the evidence that I read about hyperchloremia causing effects on renal tissue for eicosanoid release, leading to vasoconstriction and a reduced GFR, that you're saying that's not as important from what we know now?
Yes, so that has not been clinically proven, meaning they have done animals experiments given normal saline to say, hey, can we induce acute kidney injury in an animal? And it doesn't happen. So, there's theories say, hey, theoretically, this could not be good. And by the way, the fluids, there are various things that first, we don't even know if fluids are safe, by the way. It's not even, I'm not trying to spook everybody, but it's not even clear that the fluids that we're giving are safe. They literally have never been studied. We don't even know if these polyvinyl chloride bags are safe. And I'm not trying to, start a conspiracy theory. And Moritz said, "Oh my God, this thing went viral. You don't get they're killing you in the hospital." That's not what I'm saying. What I'm saying is we don't know that. Some people will not drink water out of a plastic bottle. It's like, I'm not going to drink it because there's endotoxins or whatnot, or because there's chemicals in it. And you know what? There are. And if you Google online, go Google Baxter normal saline, blah, 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 read what the PDF says. It specifically has a disclaimer about the polyvinyl chloride bag. And it does acknowledge that there's a chemical reaction. So normal saline, like if you take a glass of water and you put a pH strip in it, it's going to have a pH of 7. If you add salt to it and you put a pH strip in, it's going to have a pH of 7. The pH of normal saline is 5 in the polyvinyl chloride bag. If you have D5 normal saline, the pH is 4. You just go to the floor now, grab a bag and look at it, see if I'm right or not. It says it right on there. what's happening? There's a chemical reaction between the fluids and the vinyl chloride bag that generates an acid, and it generates an acid in the bag. So these things really have never been studied. They have been grandfathered in, and there's a study, the FEAST study from Africa, where these were kids with malaria, and they looked at kids who got bolused with fluids and those who didn't, and the ones who got bolused with fluids had a higher mortality. Now, there may be a lot of reasons for that, but it was an unexpected finding. It was almost certain that giving fluids was going to be, a good thing. So, it's a bit of a complicated, topic when, to do a really proper study, you would have to have a IV fluid in a glass bottle that's isotonic with bicarbonate. That would be the gold standard fluid. What we're studying is the best we have available. We could do better, and we should do better. But there's no, I'm throwing a conspiracy theory. There's no financial incentive for the manufacturers to do a study to improve the fluid, and they're just simply not going to do it. They simply do not care.
I had no idea this was all grandfathered, and this is fascinating information. Okay. And so then that's why when you add bicarbonate to your specialized fluids, you're less likely to get hyperchloremic metabolic acidosis, because what we've been talking about. You have to
use it right away. Yeah, if pharmacy makes it in 24 hours, you need to get a new bag. They'll put bicarbonate fluids, but it's custom, and you can do it, but you have to use it.
And in someone with normal kidneys, when you give maintenance IV fluids, not in these large boluses, you're not seeing this hyperchloremic metabolic acidosis because you're not having that dilutional effect on the bicarbonate.
Right. And whatever is happening, the kidneys can generate bicarbonate, no problem, excrete acidic urine and generate bicarbonate, no problem. That's why in our study, in our maintenance study, in the AEP statement, they found no evidence of acidosis with maintenance fluids. And it's never been reported that there's acidosis with maintenance fluids.
Okay. All right. That's what I was looking for.
Can I give an answer to a question you didn't ask? I mean, you did ask this question, this thing about hyperchloremia.
Yeah.
I'm just going out there.
Yeah, go right ahead.
You heard it first from Dr. Moritz.
That's great.
There is no such thing as hyperchloremia. It doesn't exist. No such thing. You heard it first. You heard it from me. There's no such thing as hyperchloremia. No such thing. There is no disorder called hyperchloremia. And they're going to say you're crazy. Why are you saying that?
Yeah.
Why?
Yeah.
I'll tell you why. There's only two ways you can become hyperchloremic. You can either be hypernatremic or you can be acidotic. There's hypernatremia exists, acidosis exists, hyperchloremia does not exist. The only way you can be hyperchloremic is if your sodium is high. If you have a sodium of 190, you will be hyperchloremic. You cannot not be hyperchloremic. If your sodium is up, chloride is a negatively charged particle, and it has to pair up with a positively charged particle. So if your sodium rises, your chloride rises. If your chloride rises and your sodium doesn't rise, well, how can that happen? Your bicarbonate has to fall.
Okay.
If you're acidotic, if you have a bicarb of 4, your chloride's going to be high. There has to be electroneutrality. Every sodium plus potassium needs a chloride and a bicarbonate. Acidosis exists, hypernatremia exists, and chloride is sort of an innocent bystander. But to say this person has hyperchloremia, that doesn't mean anything. They're either hypernatremic or they're acidotic or they're both. But there's no condition like, it's not a thing, hyperchloremia. It's not a condition.
So we've labeled it to hyperchloremia, but it's really, like you said, innocent bystander in this whole mess. It's either acidosis.
Right. I mean, if you're acidotic, you're going to be hyperchloremic. I mean, it's that simple. If your bicarb drops, your chloride has to go up.
That is fascinating. Now, the last section of your guideline that I wanted to bring up and talk about was the fluid overload section. So again, we reviewed who the guideline is not intended for. People with edematous states who have an impaired ability to excrete both free water and sodium. They're at risk for volume overload and hyponatremia. Patients who may need hypotonic IV fluids, you actually talk about, which I appreciated. So significant renal concentrating defects, such as nephrogenic diabetes insipidus, could cause hypernatremia if they're administered isotonic fluids. patients with voluminous diarrhea or severe burns due to ongoing free water losses. Those are patients you bring up that may need hypotonic IV fluids, because patients with edematous states such as CHF, cirrhosis, nephrotic syndrome, because of that impaired ability to excrete both free water and sodium, are at risk for both volume overload and hyponatremia. That was great. Now, I just want to make sure I didn't want to bring up anything else. What did surprise me, and maybe this didn't surprise you, it probably didn't surprise you, Mike, because you know all this stuff, is that only a few studies even looked at fluid overload. They're the ones that you mentioned, Chong et al., didn't find any difference between hypotonic and isotonic IV fluids in terms of fluid overload. And then when there was a meta-analysis done at 12 different randomized controlled trials, more than 750 kids, and there was neither weight nor net fluid balance or even discussed. And again, this is something I hear about a lot on rounds, especially when we talk to neonatologists, but this really hasn't been looked at a ton in the literature, fluid overload from different types of fluids. Am I correct?
Correct. So, and I'll just, comment on this.
Okay.
Fluid overload does happen if you have a fluid overload state. If you're in renal failure and you're not making urine, you will get fluid overloaded. If you're on IV fluids, you will get fluid overloaded. If you have congestive heart failure, if you have nephrotic syndrome, if you have, cirrhosis, if you have capillary leak, you have multi-system, organ failure with, capillary leak, and you give IV fluids, you absolutely will get, fluid overloaded. Why? Because these are fluid overload states. If you do not have a fluid overload state, though, you will not get fluid overloaded. And no one's seen that. You have not seen that. No one has seen that. Why? Because it doesn't happen. It simply doesn't happen. If you have normal functioning kid, if you have a normal, if you have a normal heart and a normal liver and a normal endocrine system and, normal kid, and they don't even have to be that normal, but, reasonably normal, you will not get fluid overloaded. Normal saline does not cause fluid overload. Now, will your weight go up? Yes, your weight will go up. Now, first of all, this could be a little bit different in the elderly who's getting a lot of normal saline. You can have peripheral edema or whatnot. But generally speaking, what we call fluid overload, hypertension, congestive heart failure, ascites and whatnot, that doesn't happen. Your body can excrete large amounts of sodium. Your body can your body releases natriuretic peptides. That's why with SIDH, fluid overload is not part of SIDH. Hypertension is not part of SIDH. Edema is not part of SIDH. Why? Because the body releases natriuretic peptides and excretes the sodium. So people do not become fluid overloaded independent of a fluid overload state. Now, sometimes, that doesn't mean that you don't watch someone's eyes and nose, and that doesn't mean you don't, watch their vital signs, and, that doesn't mean when you give someone IV fluids, just don't watch them at all. It should be viewed as a medication. I'm not saying IV fluids, don't have, certain complications. And when you're dealing with, acutely ill patients, you don't know that they're not going to develop renal failure or whatnot. There's nephrotoxic meds. There's a lot of different things that can happen. They can become septic. They can have infection. You do have to monitor your patients. But if you take a healthy person and you give them normal saline, it absolutely does not cause fluid overload.
This was such a great talk, Mike. I always give my guests an opportunity. That's all of my notes from what I wanted to bring up. Is there anything we didn't bring up that you wanted to discuss?
I think, we covered everything. I'm just going to make, a little comment about the guideline. Is, the guideline is saying, look, what's the safest fluid for most of the time, for most of the people? What's going to be the safest thing to use? And the safest thing to use, most of the time, for most of the people, is normal saline. Why? It's all when you're giving IV fluids, what are you trying? Why? Why are you giving IV fluids? What are you trying to accomplish? Well, you want your patient to have good perfusion, good extracellular volume expansion. You don't want your person become volume depleted. They're in the hospital, they can't drink, they have no access to fluids. It's very difficult to assess someone's volume status. Physical exam is very, insensitive. We have kids who can't talk and can't tell you if they're thirsty or whatnot. So we're taking over for them. And normal saline stays in the extracellular space, and you want someone who's going to be well perfused, and you want someone whose electrolytes are going to be normal and have a normal sodium. And under most circumstances, normal saline will get the job done most of the time. Not all of the time, though. There are rare conditions where people have kidneys that don't work well and they have urinary free water losses. They are rare. They're mainly patients who I'm going to be managed. And there are situations where people do retain fluids and they do have fluid overload states, and you do have to restrict fluids. So just don't think, normal saline, 150/20, I can't think about the patient. That's not the case. But for most of the patients, for most of the time, it's going to be your safest bet, and it will keep you out of trouble.
Well, I can't think of a better way to end this talk on maintenance IV fluids. Mike, thank you so much for your time. You've given over an hour. I sincerely appreciate it.
All right. You're welcome, Tony. Thank you for having me. Always a pleasure.
My pleasure.
Time for our acknowledgements. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for listening.